But,
particularly for splenic flexure. You see, we see very well left omental vein, artery. When we have to remove completely to do oncologic resection, removing the nodes, depending of this part, we understand very well that when we remove the splenic flexure, we have to do the division of the vessels close to their origin. Okay. It's better?
yeah, that's much better.
Okay. So I will stop now.
Okay.
Now you're in full control on the Zoom.
Okay. And
Because
now,
I have not seen
Here, yeah, Dan was on there just as practice.
I have not seen Cristiano. Where is Cristiano? So I have another video. I have to.
Yes, I'm saying yes, practice, run. Going smoothly.
No, non ci vedo, no?
Sì, sì.
Okay.
Andando in presentazione perché ha la modalità sbagliata.
Mhm.
Però se me li vedi qua.
Done some of these Zoom meetings the past 2 days. Like everybody in the whole family.
yeah,
Freeze.
yeah. Okay. Cristiano, you okay?
I'm okay.
Okay.
And you? Are you okay?
I'm pretty good. You know, we're stuck in our house. My poor kids are home from college, taking their classes online.
And how is the situation in Philadelphia?
Philadelphia is not as bad as New York, but our hospital, Montgomery County, is one of the kind of bigger areas in Pennsylvania, and we have a lot of the patients in Montgomery County. We have something like 80 patients in the hospital, and I think 40 ventilator patients.
Wow.
It's quite a lot for us.
It's still a dangerous situation.
Yeah, and you know, the question is how's it going to end? You know, I don't really see how you open things up. We've been doing really only cancer cases and only emergency cases. So now, are we transmitting or not? Because we should not be transmitting. We should be on hold for Facebook.
So you gotta do it on yours. It was paused on this, but not on that. All right, so if you go to the internet there.
Here.
Yep. All right. And
Che mezzo incredibile.
I gotta figure out how to pause it.
Stiamo live su Facebook.
Mhm.
Sì.
Yes, Dan here, how we pause.
Okay, so we have someone from Azerbaijan. And yeah, we're a little to the group. I'm a little afraid to come off live because I'm not sure if it's going to mess up our reconnect. So bear with us. Pat Silla has joined us. Jacob Petrosky.
Dan said to stay on.
And Dan Popowich. So very good.
You want to share just the intro screen instead of your faces? Yeah, so you better zoom down right. Hit share screen. Go to the intro slide. Go double click it. Go right first.
I should put it here.
Yep.
I see you, Cristiano.
Perfect.
Okay. Finally,
I have my, okay.
I see you very well. You know the drawing behind you.
Yes, it's a painting
Should tell.
Yeah.
of a very known Vietnamese artist.
Okay.
Exposing in the world, in New York, in States.
And in your office.
I am at home in France.
Mhm.
I have this picture in my office.
Okay. John is starting first. Abbiamo ancora un quarto d'ora.
But you see,
Disappeared.
oh, okay.
Quindi non avremo bisogno neanche di come si chiama? Vengono per fare queste cose.
Monitor during this.
Però la qualità comunicativa.
Whole part there,
Passati 40 minuti di connessione, se loro non hanno pagato, si stacca tutto, bisogna ripristinare la connessione, però è una cosa...
Una cosa?
Oh, io posso fare così, fai da te.
Ma quanta gente si può collegare?
I'm just monitoring the screen to make sure everything looks fine.
Su Facebook voi tre siete connessi così, ma tutto il mondo vi vede su Facebook, dove stavo cercando di vedere di qua.
Unless you put a earpiece in or something. Do you have headphones?
Solo che dicono la pagina SAGES, ma non c'è mica.
If you wanted to listen, even here is just the one, I guess. If he has his laptop in here, there'll be background noise.
Okay, guys, well, another few minutes and then we will see, okay?
Okay.
So let me ask you this, though, Charlie, is when I'm like this, I can't see who's signed in.
Io sto vedendo Facebook insieme a 37 persone.
You have to control Zoom and the Facebook side.
Il ritardo di 20 secondi.
Both computers to be able to monitor.
È piccolo, si vede?
Beh, sul telefono Oh, sì, sotto vedo i commenti della gente, c'è Patricia Silva connessa.
That's so, not Dan, but another doctor, over thing. Basically, he said for him to do it and monitor questions. As the moderator, he had two computers up and running at the same time.
So could I do that?
Yeah, we do that.
You guys are live, you know that, right?
Mhm. Then do you guys have another computer?
Sam.
Well, I need a second computer here. Is the problem.
Patricia. Patricia Silva?
Mhm.
Live stream.
Popovic, dov'è?
Daniel Popovic. Gli altri non so chi sia.
Yeah, double click on it.
2 minutes more. 6 minutes more.
This here.
6 minutes more.
Which one?
So far, right? We could try this.
Peccato, no?
So now why is he coming up? Just him? Probably.
Yeah, just talking.
A parte il dubbio di non aver riconosciuto una disciplina sull'aeroplano. Diventa pizza aspettata in auto alle 6, alle 9. E quelli due erano a dormire, io sono rientrata.
Try toggling over one of those little icons right there. It's like your lighter. Up above them. Like that. Oh, right there. 47.
Okay. So when do you guys think this is all going to lift?
We're ready.
So the thing is
4 minutes more.
just, can you just have Sam like poke his head in once in a while and let us know that?
Just like a thumbs up.
Tell him to sit right there. Well, the bewitching hour is coming.
The Wall Street trader.
Yeah, right.
Capellini come i nostri azzurri. Okay, we're ready.
Okay, guys. Well, everyone, it's 4 o'clock, and I'd like to welcome you to our SAGES Colorectal Surgery Master's Program. I have to give a hats off, tip my hat to Dan Popowich, who has really spearheaded trying to put together some educational product during this period of time when we've all had our worlds completely rocked by this pandemic. And rather than do something virus related, I thought what we would do is take advantage of the collective expertise of some in our group and share with you something that should be helpful, I think, to everyone practicing colon and rectal surgery. So this is a painting of Dr. Gerald Marx's, and this was actually the World Congress painting from 2018, which I had the pleasure of being the program chair. And so we're going to talk about left colectomy. And with us today, we really have two of the giants in the field of laparoscopic surgery, not just laparoscopic colorectal surgery, but laparoscopic surgery all over. Cristiano Huscher is coming to us from Italy. He's really been the champion of complicated and complex colorectal, hepatic, esophageal, pancreatic surgery, you name it, he's done it. And I have to tip my hat off to him and Joël Leroy, who I first met in a small town in northern France. And then he spent the last decade and a half at EarCAD help Jacques Maresco make it what it is. And then he's recently moved to Hanoi, where he has a beautiful center, and he continues to do this phenomenal work. And I'm coming to you from Philadelphia. So we're going to really talk about using different approaches to make the same, it's definitely the same recipe. I mean, a left colectomy has the same steps, and what we're going to do is talk about different ways to do them. You know, Sir Isaac Newton said we can see further because we stand on the shoulders of giants. And, you know, as a young man, which was a long time ago now, I sought these gentlemen out to help me get started. And then in the middle here, I have my biggest mentor, Dr. Gerald Marx, who some of you may know as the father of SAGES. He's also the artist who's done all this artwork. And I want to just say before I forget, a happy birthday to my father, who's also the father of SAGES. Tomorrow, he turns 95. So way to go, Pops. Keep strong. He's still fit and active. He's down in Florida, staying safe. So we're going to talk about left colectomy. And what we're going to do is get started with Joël, who will talk with us about his laparoscopic approach. And then we're going to go to Cristiano, who will be presenting some laparoscopy and robotics, XI robotics. And I'm going to show you some of the stuff I've been doing with the SP robot. So, Joel, why don't you take over the screen now?
Yeah. Good morning, good night, good evening. I don't know, but hi everybody. I will share. You are sharing your screen, so I cannot do.
Yeah, I just stopped sharing my screen.
Okay, good.
Now it's you. Voila.
Voila. Okay. Is it okay?
Yes.
Yes or no?
Now it's good.
Okay. So my financial disclosure, it is important for SAGES, and a lot of people are saying I'm a robot. You see there is some malicious robot existing, and I have to prove I'm a human, and I confirm I'm not a robot. This is my center where I'm working in Hanoi, and I'm the founder and chairman of this center.
Joel?
Yes.
You may want to put it to presentation mode.
To presentation move. I'm not?
I have.
You have?
Yeah, I have.
Okay. So I don't know.
Just
What
the bottom right here.
I will do. So presentation move. Partager. Do you see the screen or not?
Two to the right. There you go. Voila.
Okay. So you asked me to speak on left colectomy, and as you know, 30 years ago, we began to do this by laparoscopy, and it is a huge challenge, and I'm a paleosurgeon working since the Paleolithic time of laparoscopy. And I will try to explain what we standardized 30 years ago. Performing a laparoscopic colorectal oncologic resection is always challenging, and we have developed the standardization of the procedures for doing them safely in by laparoscopy. In oncology, we have to respect some principles, and to have oncologic resection, it is recommended to have a minimum of 12 nodes, a distal margin more than 5 centimeters with cylindrical division of the meso, and a proximal margin minimum of 10 centimeters, same for the division of the meso. Avoiding to manipulate the tumor. This is a no-touch technique described by Turnbull, and standardization with, as we do since the beginning, CMD, that is complete mesocolic dissection or resection. To do a perfect oncologic resection, we have to remove, and it is a consensus between surgeon pathologists, to remove the node depending of the segment of bowel with examination of a minimum of 12 lymph nodes, even if there is no real evidence base for this conclusion. it is important to know the anatomy of the nodes. And as you see in the Japanese classification drawings, you have different type of nodes. Epicolic against the bowel, paracolic, just close to the bowel, intermediate in the meso, and the principal nodes at the origin of the inferior mesenteric artery. And it is rarely at this place that we will have positive nodes without other nodes positive in the meso. We have to remove, when we do left colectomy for cancer, the nodes at the origin of the hymen, the group 253, and to remove the 252 and unblock resection of the meso. You have to know also perfectly the vascularization and the different variation of this vascularization. For the left colon, it is depending of the inferior mesenteric vessels. As we see, we have the left colic artery for the splenic flexure. We have the sigmoid trunk for the sigmoid and descending colon. And we have the inferior, the superior rectal artery coming from the hiney. The venous drainage is depending of the inferior mesenteric vein with sigmoid vein, rectal vein, and left colic vein. Finally, we have 3 segments for the left colon, for the depending of the vascularization of the hymen. Splenic flexure, the descending colon, the sigmoid. As you see, we have a lot of variation, and it is important to understand and to know this when we do surgery. How I do it? First, the bowel preparation. What I do before surgery. It is important to have a perfect colonic bowel preparation, particularly in laparoscopic surgery, but not only. Because colonic mobilization is the manipulation of the bowel and the colon will be easier. It will be easier to localize small tumor using endoscopy perioperatively and reduce the risk of bacterial contamination. And particularly in Asia, in States too, not in Europe, because there was no recommendation to do bowel preparation in Europe, except for rectum. I use now, because it is what we do in Asia, in the majority of cases, we use preoperative mechanical bowel preparation with oral antibiotic to reduce the risk of infection, the risk of anastomotic leak and ileus. And there was a multivariate analysis of this type of preparation. And there was an incidence concerning the rate of leak. We will see 3 types of colectomies. Complete left colectomy. And this is why we do that in majority of West countries, because quality of the sigmoid is not so good than in Asia, where there is no diverticulosis, where there is less fat patient, and we do more extensive resection in West countries than in Asia. In Asia, we can respect the oncologic principles we have seen before. We will see sigmoidectomy and splenic flexure resection. What we do to patient position, we use Lloyd-Davis position, both arms along the body, and using a good positioning with fixation to have the possibility to move the patient on the table with a remote control. For concerning the team, I'm operating with one assistant, that is a cameraman, the first assistant on my left. All the teams stay on the right side of the patient. And the second assistant will stay between the legs to retract and to do the anastomosis. Laparoscopic unit is on the left side. I know that in the States and Asia too, because a lot of patient surgeons are trained in States. The second assistant is on the left side of the patient. In this case, you have more screen to use, and it is a solution I propose to use only one screen with laparoscopic unit and the scrub nurse. Number of trocar, 5. You will see that we can do with less, 5 trocar to perform the procedure easily. And I recommend to do that at the beginning. We can do with 3 trocar, with transanal specimen extraction. We can do with 1 trocar, and we will have discussion with all the panelists. Concerning the first step, it is exposure. To do perfectly, safely dissection, it is necessary to expose perfectly. What we will do, we will put the patient head down with a right lateral tilt to retract the small bowel on the right to expose the aorta, the axis of the mesosigmoid and the pelvis. We explore completely before to eliminate metastasis. Concerning the first step of dissection, it is a primary vascular approach, primary proximal IME dissection and ligation in the standard we do in advanced cases particularly. We will do a skeletonization of the IME close to the aorta, not skeletonize the aorta because there is a lot of plexus running around, and we will divide between clip and using a perfect atraumatic dissection to respect the nerve. We will see after. Then we will divide the IMV at the same level or close to the inferior border of the pancreas. We will see better later. As you see, we have the plexus trunk, superior hypogastric plexus with a branch running, going around the hyme and running around the hyme. And it is this branch that we will divide to finally dissect and skeletonize the vein and ligate and divide it between clip. That is better. Then we will do the left colonic mesocolic dissection using the CMD and the splenic flexure mobilization in European standard procedures. As you see, we can do, and we will see later, how to do mobilization of splenic flexure, but by medial posterior approach, dividing the root of the transverse mesocolon anterior to the pancreas, we dissect, reaching at this level the hilum of the spleen, where we will find the left omental vessels. We will divide separately artery and vein to remove and block the omentum if necessary. Next step, after finishing mobilization of the descending column, and we will divide the distal column at the level of the colorectal junction, and divide, doing a skeletonization, as I said, minimum 5 centimeters under the tumor, to divide the eye rectum, and using a stapler for doing the anastomosis. Anastomosis is done after we do extraction of the specimen through a small incision. We choose suprapubic incision. I know a lot of surgeons use the incision in the inferior left quadrant of the abdominal cavity, but suprapubic is easier to enlarge, to remove big specimen with low morbidity, particularly late morbidity concerning incisional hernia particularly. Question: what to do? Low or high ligation? There is a lot of paper concerning the high or low ligation. High ligation, you have more of the inferior mesenteric artery, more risk of anastomotic leakage. In meta-analysis, it was demonstrated. So if we can avoid, it is probably better. So can we do distal division of hyme and preserving the left colic artery, who have possibility to take down the splenic flexure and doing the anastomosis with a segment of column well vascularized. If we do in oncology, we have to remove the node at the origin of the hyme before the left colic artery. It is a skeletonization of the origin of the hyme. And as you see on this picture on the right, we will skeletonize, removing en bloc the nodes in the meso. And in this case, we have the superior rectal artery, the left colic, the sigmoid trunk, and the left colic separate. And we will divide, in this case, the superior rectal artery and the sigmoid trunk, keeping the left colic artery. So we can do that. How doing a mobilization of splenic flexure, and why doing it? There is a lot of discussion concerning the mobilization of splenic flexure, and we will see the literature. There is a good paper of Robin Kennedy from St. Mark's, a good friend of ours, that analyzed the literature. In Asia, we don't do systematically mobilization of splenic flexure for sigmoid, for rectum, high rectum, not low rectum, where we will do mobilization. And there was a paper, interesting paper, they analyze and they demonstrate that high ligation were done and mobilization of splenic flexure only in 25% of cases. They try to reproduce in a Western country population, and particularly they do in Dublin this, and they have the same possibility. So when we wish to do, we can do the preservation of the vessels, left colic, and not a complete mobilization of the splenic flexure. When I say I don't do systematically mobilization of splenic flexure, I do regularly lateral freeing of the attachment, but I don't do a complete mobilization of the splenic flexure. Complete mobilization, what it is? You see, this is complete mobilization. Left sac is open. The attachment of the transverse mesocolon anterior to the pancreas is divided, and lateral attachment and posterior are completely divided. This is what we see there. You see the lateral to the duodenojejunal junction. We continue to open the peritoneum, and we do a window and we see the pancreas. Rapidly, we continue the dissection in the direction of the root of the transverse mesocolon. We open the lesser sac, and anterior to the pancreas, we see the attachment of the transverse mesocolon, and we divide it till we reach the tail of the pancreas, and slowly and safely we continue the dissection till we see the left omental vessels, artery and vein, and as we see, we will divide. This is the vascularization of the trunk for the omentum. And when we do oncologic resection, we have to remove, particularly when we have splenic flexure tumor. Other step, and Cristiano is beginning by this approach, we have to divide the attachment of the omentum to the stomach, keeping marginal vessels, and we continue the division laterally till we have completely detached the omentum. And I remember we divide the vessels before by posterior medial approach. This is how we do a complete mobilization. Lateral freeing is not a complete mobilization, but this can help the possibility of mobilization of the splenic flexure. In conclusion, mobilization of splenic flexure, for Robin Kennedy, a selective approach to mobilization is most likely a benefit for the patient. Segmental colectomies, limited colectomies, we will see for sigmoidectomy. This is a T1 SM2 tumor, a big polyp resected by endoscopy, T1 SM2. This can be a good indication of, in early sigmoid cancer, to do preservation of the vessels, removing all the nodes. This is a technique described by Junji Okuda. And I use tools of Junji, the spatula of Junji. You see the hyme dissection. We continue the dissection. We do skeletonization, removing all the nodes inside the meso. And it is necessary to do skeletonization. This is a suprarectal artery. This is a trunk with left colic and sigmoid trunk artery, left colic, common trunk. This is, there is a lot of variety, and we have seen before that we can have separate branches. We divide the sigmoid trunk. I remember it is a sigmoid polyp at the summit of the. We try to find the vein, IMV trunk. As you see, we separate. The left colic is passing above or behind. Majority of cases, I will say 60% is anterior to the IMV. it is a superior rectal vein, the IMV, and we will dissect and see the sigmoid trunk of the venous drainage with, as we will see later, sometimes other branches, more distal. This is distal sigmoid vein. Sometimes it is a vein with anastomosis, with a rectum. This is what we call sigmoida imma. And we have to do a perfect anatomy dissection. As you see, we just finish. When we have finished, we have kept all the vessels, IME, left colic, venous drainage, and superior rectal. Advantage is to keep a good vascularization of the rectum when we do a segmental resection, oncologic. And particularly, it is important to preserve the nerve first, but also to preserve a good drainage, avoiding, sorry. In summary, when we do laparoscopic left colectomy, we can do safe and oncologic surgical procedures. We always recommend to do bowel preparation with antibiotherapy now, because it seems it's best actually to have good results. We are doing a prospective study, but not a lot of people are doing. Splenic flexure mobilization, we customize. If necessary, we do, and we have to know how to do, and all the steps of the complete mobilization. We can do also more limited, more segmental resection, oncologic, removing the nodes. We have seen at the beginning the nodes we have to remove. And when we do a segmental resection of the splenic flexure, using laparoscopy, it's fantastic. Thank you for your attention.
Joel, that was fantastic, as always. And
thank you. I hope it was nice for the fantastic for the transmission.
And just for the group, if the audience has questions, feel free to type them in and we'll try to get to them. And for everyone, we have over 100 viewers from so far from 4 of the continents. So let's now we're going to switch over to Cristiano, who will talk to us about some robotic approaches. Cristiano?
Yeah.
No introduction.
Do you see my slide?
Well, perfect.
Difficult.
Yes. Perfect.
Difficult for me speaking after Joel. But anyway.
Somehow I think you'll be okay.
But anyway, fortunately, I have to speak about robotic left colectomy. It doesn't do. And so I want to try to explain my experience and how easy and how safe it is to do a robotic left colectomy, especially for an old surgeon like me, who is very often tired. So we start to explain some anatomical details, which are very important in this technique. We start from IMV, specifically where the confluence of colic vein is, and this part of the vein was very well described by Trice, and it is called Trice Arcade. We start exactly there, and we try to open a window between gerotas and told fascia in a very special corner where we can recognize the renal vein and the gonadal vessels. I try to show you the confluence of left colic and the IMV, which is not difficult to recognize in our patient, especially if the BMI is low. We lift up the vein and we try to recognize the right plane between gerotas and tall fascia. The vein is very well visible in the field, and we can lift up in order to open a large window. Slowly and gently, we try to find which is the right plane, and to be sure that we are in the right plane, we have to recognize a white line that we call Joël Leroy line, because he described it many years ago in the beginning of laparoscopy. And you can see after that, we have to describe the fusion between told and gerotas fascia, very well described in 19th century. And you can see two drawings where you can find the two fascias and the plane you have to follow in front of the kidney. And when the space is created, we can clip and divide the vein. We have to stay very close the confluence of the IMV into the splenic vein. If you stay high, you stay safe. And after clipping it, you divide with the scissors, and you are ready to open a window in the transverse colon mesentery. Just to do the same thing that Joël described in the movie some minutes before. This is the window we open in the transverse colon mesentery, close to the left branch of the middle colic, and we start to lift up the two wings in order to dissect free the pancreatic tail from the transverse colon and descending colon mesentery. You can see the pancreatic tail, which is appearing in the field, and sometimes we can find some vessels, minor vessels, and going slowly, we can dissect free all the pancreatic tail just to the splenic hilum. And the procedure going on, dissecting free the IMA. To do that, we have to recognize the Gruber fold, which is the sigmoid colon mesentery, which is very well described in this drawing done by Gruber himself. And we have to go close to the aorta, where the IMA is coming out, and this region is called by Bacon axilla. It was described in 1955 in the American College of Surgeons to perform an high ligation and a 3-step lymphadenectomy. This is our fold, lift up, and we go straight to the IMA, close to the aorta, and we check the position of the IMA origin, and again we open a window between these vessels and the distal part of the aorta. The dissection of IMA is not difficult, but again, it's very important to remove all the nodes close to the IMA origin and to spare the left colic artery, like in this case. We put a clip close to the left colic origin, preserving the left colic itself. And we clip again the IMA, and we're ready to divide distally the IMA. And going on, we have to find the plane, the right plane between Gerotas and told in front of the promontory, which is called the Holy Plane by Bill Hilt. We call him the Pope for that. And at the same time, we have to recognize immediately the Valdayer fascia exactly below the promontory. This is done in such a way, lifting up the sigmoid colon mesentery, and in this way we can expose the last part of the Gerotas. We can recognize the left ureter completely covered by the Gerotas, and at the same time we can recognize the promontory and the Valdayer fascia, like in this traction. And so we are ready to find the right place where we have to transact the junction between upper rectum and sigmoid. How we can do that? How we can be sure that we are in the right position? We have to find the bifurcation of IMA into right and left rectal arteries. And it was very well described by Henri Mondor, and it is called Mondor hilum for that. We do that without any stapler. This is the reason why I like a lot this kind of resection. We can transact the rectum, the upper rectum, and we can check the color of this part of the rectum, which is ready for the anastomosis. The left colon, if it is not a huge specimen, can be retrieved through the rectum with a bag, otherwise through a mini laparotomy. And what we do after that, we ready to do an hand-sewn robotic anastomosis, which is very safe in my opinion. We can do a posterior running suture. We can check the two cuts surface of the two remnant, the rectum and the left colon, and the running suture can be done in such a way very safely. The anterior running suture is more easy, and it has to be done in a proper way, just to avoid any leak. But anyway, as you can see, the two part of the colon can be approximated in a proper way by this second running suture done with a V-lock suture, which is very useful, especially for robotic anastomosis. I know that we are coming back from stapler anastomosis, which are very safe. But anyway, I think that this one can be safe as well. And at the same time, we can check the color of our colon and rectal stamp. So we are sure that we can do a safe anastomosis, and probably the leak rate is as good as we do in Knight Griffin technique. This is my way to do a robotic left colectomy in a very simple way, and I think with very good results. Thank you for your attention.
Fantastic. Really a wonderful demonstration, and a lot of great history, a lot of great anatomy demonstrated. And I think what I'm going to do is show my part, and then maybe what we can do is have a little bit of a discussion. What do you guys think?
You present yours, and then we can discuss all together.
Perfect. Where do I go to screen? Okay. I'd go here. Or here?
Right there.
Wow.
Okay, boys and girls. All right. Hey, it's nearly impossible for me to look good following these two guys. And I just want to share with the group and the world, when I was younger, I went to visit them, and I owe a lot of what I do now to them. And it's really my pleasure to have been able to take what they've given me and be able to share it with many on this webinar, as well as others around the world. And so I'm going to talk with you. This is a painting of my fair town of Philadelphia. This is done by Dr. Gerald Marks. And this is where I work at Lankenau Hospital, just outside of the city of Philadelphia. I really have to give a shout out to my team here, who work very hard to help us do these things and really give me the time to be able to do this stuff, because they're doing all the hard work. So anyhow, you're my consultants. I'll speak to whomever's interested in speaking to me. Sometimes they're nice, sometimes not so nice. But anyway, this is a slide that I think is an important notion. It has to do with the effectiveness of a surgical operation. It says the effectiveness of any operation is determined by the level of technical difficulty and therefore how many surgeons can perform the operation with a good clinical outcome. I mean, we've seen these videos by Cristiano and by Joel. Beautiful, beautiful operations, but it raises the question, if an operation is so difficult that few surgeons can perform with a good outcome, it's effective in their hands, but has limited effectiveness worldwide in surgery. So any technology which reduces the technical difficulty in the execution of an operation will automatically increase its effectiveness and therefore indirectly benefit patient care. And so I'm going to talk with you about a robot and see if a robot does that, particularly this single port robot. You know, I've spent a lot of time struggling and working to do things better. And when we teach, and again, I have to pay tribute to Cristiano and Joel, who helped formulate this and develop this. But I like to talk about when performing an operation, breaking an operation into directly productive versus non-productive activities. And what I mean by that is every time you have to switch an instrument, every time you have to aspirate, every time you get into the wrong plane and have to come back to the right plane, that's non-productive action. You have to do it to get through the operation, but it's different than when you're in the proper plane, properly oriented. And so if you can standardize an approach to do things, it's going to improve the efficiency of the operation. And in so doing, we're using gravity for retraction and trying to keep repositioning to a minimum. And so, you know, I've gone from the multi-port approach, which Joel, and then the 3-trocar technique of Huscher, honing that down to single port surgery laparoscopically, and then using that to do single port robotic surgery. I'm going to show you what this looks like. So these are the 9 steps of the operation. We generally do this in a standard fashion this way. And it's like a clockwork, like a production model of doing things. So this is like Henry Ford building the Model T car. First, the splenic flexure, then position the small bowel, IMA, IMV, mobilize the colon, et cetera, down the line. So, you know, these are a picture. I've been working on this SP robot dating back to, 4 or 5 years now. And so I was so excited in 2018 when this got here. I went down to meet it on the delivery dock. These are the instruments that exist for this. So there's a clip applier, the Maryland bipolar, another grasper, a needle driver, a bipolar, and the scissors. As of right now, these are the only instruments there. There is a lacking of the ligature and the suction and the stapler, which are real drawbacks, but we've seen this in other robotic forms, and clearly these things are on the way. So for those of you who haven't seen it, this is what it looks like. This is a 2.5 centimeter trocar that has a camera and 3 arms articulated at the elbow and the wrist. So in all, there are 4 arms, 3 of which are shown here. This is what the introducer faceplate looks like, a slightly oval area for the binocular 3-dimensional camera, and then the 3 instruments here. It's always introduced through a gel port in order for the assistant to be able to pass a needle, put in suction, et cetera. So this is what it looks like. We're going to do this through a single port. We're cutting down. This is the standard approach. Always put a wound protector there. And this is the port we're insufflating. And then this is showing the port coming, the robot coming up. It's very quick and simple to dock. On average, it takes us about 3 minutes to dock. And this is showing the camera coming in. If you look up here, you can see the field. And this is showing the instruments being inserted into the abdomen. over here, you can see the arms as we look at things and we look around all together. So these are the three arms. This is the assistant coming in there, because you're going to need the assistant to use the ligature to help you. Okay. So, this is what it looks like. This is the camera movement. You can see this is a big kind of C-arm. And this is demonstrating the assistant bringing the instrument in and out. It's much safer and more comfortable for the assistant than the XI and the SI robot, where they're constantly in danger of getting clocked in the head by the moving arms. And then this is what it looks like in use. Here I am back at the console. You can see this is pretty similar. This is what it looks like up top. And then this is the movement down below. And it's just helpful to get the whole look of things. Here's John Joss, my fellow from last year, holding things at the bedside. And you can see it's quite simple to move things around. I'm just taking a little bit of time to show people the new technology. And then this is us taking down the splenic flexor. So this is the first approach. The patient's in reverse Trendelenburg, right side down. The elbows come in. And so you can do this with 3 arms or 4 arms. I'm using 3 arms for this, 1 for the camera. This is the assistant coming in through the ligature. And again, this is opening into the lesser sac. And likewise, it's always the same steps of the operation. We're not making things different. We're just doing them in a little bit of a different orientation and order. Here I am helping the assistant with the ligature. So we're opening up the lesser sac as far as we can. Then we're mobilizing the upper portion of the line of Tolt medially. I'm using the scissors as kind of the hook there. You can see we're using the full articulation, both of the elbow and of the wrist, in order to mobilize things. And then taking this off of the retroperitoneum so that this is fully mobilized. You can see this is entirely mobilized, as was shown in the inframusicolic approach that Joel so beautifully showed, as did Cristiano. So once this is done, we just undock the robot, and there's no real downside to doing that. And then we are using gravity to retract the small bowel out of the field. So you can see this here. We're grasping this up and out of the way. And then putting the small bowel out of the field so that we can see Gruber's ligament. We're incising that here and sweeping this down. This is really more part of step 3, which is the IMA and the IMV dissection. So we've incised the Gruber's ligament, and then we're going to open, I like to open just the peritoneum and separate down the retroperitoneum from the underlying aspect of the mesentery of the sigmoid colon. We then went above up to the, I'm sorry I didn't show that better, up to the IMV, and developed that same plane that you've seen before. And then this is showing us coming through here with the assistant's ligature in order to take the IMA. This is the plane, continuing to develop the plane medial to lateral, sweeping that down. So we're separating kind of the pages in a book. So we've seen the ureter. There it is again. We're just mobilizing the peritoneum, the retroperitoneum off of the underside of the mesentery. And here we are taking the dissection medial to lateral. Not sure how we lost taking the IMV there, guys. Somehow we missed that part of the video clip. But here we are now mobilizing the colon. And most of this you'll see has already been done. It's worth noting down here at 6 o'clock, this hologram, which is a fantastic modification of this technology, which allows you to see the orientation of all your arms as they're working. And then this is just showing, finally, once you've mobilized things, completing the dissection further down into the pelvis. Here are the hypogastric nerves, which are the key to the operation, pushing them posteriorly. Deciding the level of transection, which in this case is the upper rectum. We find the confluence of the teni coli to make sure we're out of the sigmoid colon and into the rectum. We've gone posteriorly then to the left side, taking the mesentery as we come into the rectum itself. Sorry, guys. I'm hold on one second here. A little technical difficulties. So why can't I get it into them? Okay, we're going to do this again. So we're coming underneath the mesentery and then bringing it down the left side and making sure we don't corkscrew it. So we want to make sure we're at the same level to the left and the right of the mesentery. Once this is done, we always irrigate out the rectum. So that we can get ready for transection. So the stapler is coming in from our assistant port. This can be a little bit awkward. We're clamping this and then transecting it. Stapler's coming in from. So this is the next firing of the stapler. In from our assistant port. And you can see we've completely transected the rectum. Once that's done, air is desufflated and the robot's undocked. This, I think, this part of the operation accounts for a little time saving as you're already ready. We like a clean, dirty technique. The specimen's exteriorized. And here we are putting on the automatic purse stringer and the anvil. So making sure there's no diverticula in the anvil, tying this around and then dropping it back into the abdominal cavity. Patients then put in Trendelenburg again, right side down. The robot is brought in. There's Jean Stolem, one of our chief residents, in the French position. And here's the stapler coming in. You can see how easily it is to position things. Again, take a look at the hologram here. It's showing the camera. And then I'm just using two of the arms here because this is a relatively simple task. Pushing this down and mating it with the anvil and then closing this for the anastomosis. This is how things look like from below. We're stapling and we're done. Doing an air leak test at the end, filling with saline and then blowing air in. And we do not close the mesentery, but we always make sure there's no small bowel there. And this is just showing the amount of blood loss in the suction canister afterwards. Here's the specimen, and this is what things look like. So the incision there measured 4 centimeters. And this is a variety of SP robots post-operatively. In the last year, we've done about 15% of our left colons with the SP robot. We've had no conversions, no major morbidities or mortalities, mean blood loss about 80 cc's. And so it's my prediction that the SP robot will usher in a new era in SILS as the technology improves, so will its uses. What we're looking for is to see if, as a team, if as a group involved in surgery, we can improve our function, much like this Ferrari team here. We haven't quite gotten it like this in our operating room, but Cristiano and Joel, we're working on it. Maybe you guys have it there. So, you know, with that, I'd like to stop and open things up for conversation. Anyone who has questions, please feel free to put them in from the audience. And with that, I'm going to open things for comments.
Thank you.
Super.
So we have a question. Does the SP of Firefly? And the answer is no, not yet. You know, I think all this stuff is going to happen. And it's basically, they spent a lot of engineering time and a lot of computer programming time trying to get things to work. Someone writes, Dan writes, I'd like to see a suprapubic approach. That would be fine. I find, personally, I like the muscle spleen incision in the right lower quadrant the best. I find that our hernia rates are next to nil with that. And cosmetically, as you can see, it's quite good. We've done rights and we've really done everything at this point. Rights, lefts, the works. Cristiano or Joel, I'm going to start with you questioning me and then I'll question you. Any questions for me about what I just showed?
Yes, I have one.
Go ahead.
May I put a question?
Yes, yes.
Which is the procedure you think is more convenient for SP in colorectal surgery?
So I think right now the biggest helps are in TEM, SP TAMIS. I think the TATME is very good with the SP. The abdominal cases are very easy, but it's a little frustrating to have to use your assistant to use the vessel sealer. I think as that becomes available, you'd end up wanting to use the SP almost all the time.
And which is the most convenient step in a left colectomy with SP? Artery, vein, splenic flexure, anastomosis?
I think you know, it is very facile in terms of dissecting out the artery and the vein and doing the lateral dissections. You have 3 arms at your hands very simply. It's far enough away from your entrance site that you have, you know, the arms come out like this and they have to come past the fascia for the elbows to come out and then to move. So if you're trying to operate too close to the entry, then it's a problem. But as you get further away and dissecting out the IMA and the IMB are that way, it's why I think a suprapubic incision to go down in the pelvis would be a little awkward. And I don't really see the benefit of that. But it's a very simple step from the XI to the SP. And I think as it becomes more available, a lot of people are going to want to use it. What are your thoughts, Joel?
What I'm thinking, I have seen, you see, it's very often when surgeons are using new technology, they compare technology and surgery and technology we see with Formula One race car team. And I remember changing the wheel was taking 1 minute, beginning of Formula One race car. And now it's 2 seconds. But we have seen with you, to change the wheel in 2 seconds or less than 2 seconds. but have you seen how many people there were? There were 20, 30. So is it the same when we will do robotic? Because advantage of robotic is to reduce the cost in industry. The only domain where we increase the cost is in surgery. So we have the problem, how many this will be the cost for the benefit we will have for the patient.
I mean, I think these are excellent points, and really, these are all things that we can do differently. You know, this is a state, surgery is a field that's in evolution, and it's going to take some time to figure out the best and the most efficacious way to do things. And clearly, I think that there is some benefits in terms of the facility of the single port robot to do things single port and have the robotic dexterity. The cost is clearly going to be an issue over time. I think that'll get better, but it's something to be hashed out. You know, Cristiano, we have a question from the audience saying, if you could explain more how you do your hand-sewn anastomosis, how do you line it up? What suture do you use and what needle are you using? And are you doing a simple suture or two single layer, double layer posteriorly or anteriorly?
You know, I started my experience in hand-sewn colorectal because last year I did 36 esophagectomy, robotic esophagectomy. And of course, I did my esophago gastric anastomosis hand-sewn because it's very difficult to introduce in the chest a stapler. And more the leak rate of stapler anastomosis in the chest is quite high, still quite high. So starting the hand-sewn anastomosis, we had immediately an improvement of our results. So I decided to do the same for right colon and to do the same with the left colon. And till now, so far, I am so happy. I use usually a silk suture just to approximate the two stump, and then a 3/0 V-lock anchored suture, 3/0, and usually I do only one layer or one suture, except the case where I see some hole or
weakness.
Yeah. And in the posterior aspect, I do the same. Very often in the posterior aspect, I put some suture separated stitches just to maintain or to cover the running suture. And I think that I am very happy. I can take 2 or 3 or 4 millimeters of tissue when I do my running. And so it's very difficult to have a leak. It's very difficult to have a leak. We have to test with green indocyanine, of course, or we test the color of the mucosa. Inside, the color is quite important because if you have a good mucosa, bleeding mucosa, usually the two stump have a good blood supply, usually. In the right colon is the same, and in the right colon, of course, is much easier. The position of the running suture is not so easy, especially when you go far away from the promontory. But anyway, XI is a very good robot, so we can reach even the middle part of the rectum quite easily.
Fantastic. Joel, what are your thoughts in terms of when to do hand sewn versus when to staple?
No, I did by laparoscopy answer for right colon, but you see, I think it is coming back 40 years ago, because there was a discussion when in the 70s when circular stapler arrived on the market. And there was a competition between the old surgeon doing suture handmade, and the young surgeon wanted to use stapler. And competition, we were demonstrating cheaper for sutures, faster for sutures, because old surgeons were very skilled. They are doing suture very rapidly. And the problem was few surgeons were able to do low colorectal, or I will say mid-rectal, or distal rectal anastomosis. And there was a lot of patients with definitive colostomy. With the introduction of the circular stapler, we have seen a real revolution. So we have discussed of the cost of the stapler, but we have seen that because stapler were introduced on the market, more patients had low colorectal or mid colorectal anastomosis, even by non-expert surgeon, because this is a huge advantage of the circular stapler, having the possibility. The question is it with a robot the possibility to have more surgeons doing low colorectal anastomosis? I'm not sure. It would be always with a circular stapler that we will do. And in macroeconomy of health, advantage, even if it is expensive, if more surgeons can do, if more patients can have a benefit of using new technology, better it will be, because the cost will be reduced, because the care for all the life will be lower.
That's an excellent point. Hey, another question has come in. In terms of high or low ligation of the IMA for cancer, do you believe that meta-analysis that by leaving the left colic, you're having less leak rates? And because the issue's always brought up that there's a problem with length, and the length problem generally is relative to the inferior mesenteric vein. And if you leave the left colic, do you leave the IMV intact, or you take the IMV? And if so, is there any issue in terms of venous drainage?
Concerning high ligation, we are speaking of arteries, high or low ligation. This is only for artery. Artery, we have in Asia, in Japanese school, have demonstrated that there is no oncologic advantage doing high or low ligation if you remove the nodes at the origin of the IMA. if you do skeletonization, so you keep the left colic artery, is it useful to mobilize the splenic flexure? If you see the left colic, if you free posteriorly all the meso, you can understand, you can take down the splenic flexure if you turn the left colic artery. Concerning the vein, when I do sigmoiditis, operate sigmoid for sigmoiditis, I always keep the vein to have a better venous drainage, because if you divide the vein, the venous drainage of the rectum will be by the hypogastric vessels only, so you will have a local congestion of the venous drainage. If you keep particularly the inferior mesenteric artery, you will have 80% of the flow, the blood that will come to the rectum. So high pressure, and you will have a congestion of the venous blood in the rectum. So it's better if you keep the artery to keep the vein, to have a good drainage of the rectum concerning the vascularization. Can we do? Yes, you divide only the left colic vein, not the HMV. If you keep the HMV, you keep the drainage, for example, of the sigmoid, of the superior rectum, superior rectal vein, and you can do, I can send to you movie showing the possibility to do that. And we keep the margin vessels for the drainage.
Cristiano, what are your thoughts on that?
I have 2 or 3 issues. The first is cost. I have to remember that in Italy, I don't know in US, but in Italy, technology cost is about 9% in a hospital money. So if you want to spare only on 9% of the money, I think that you can spare very little. The second question is spare or keep or not keeping the left colic artery. I usually do that, but when I have a very high BMI patient, for me, it's very difficult to clean the origin of IMA. For Joel, everything is simple, because I saw him many times in Strasbourg with a very, very high BMI patient, cleaning everything. But usually for the other people, it's not so simple to reach a good lymphadenectomy keeping the left colic. But anyway, in the literature, we find that keeping the left colic, it could be much better. And it's all what I have to do. I have to say.
I would say
I can do answer. You are right, and I said it is we can do anatomic dissection respecting oncologic principles, particularly in slim patients. You explained it's not possible in the patient you operate. But when I see your movie, it's always a slim patient. So why you don't show a demonstration of keeping when it is possible to keep? My question is, my comment is, can we do oncologically? Is it possible technically? I say yes. And we can respect oncologic principles, keeping, and we can technically perform, and I will say particularly in Asiatic patients. But I was able to do in Europe too. So, but in States, I know you have very, 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 very obese patient. So it's not a possibility. I cannot answer for that, but I'm sure it's not really possible.
I think it's important for the audience to hear and see what can be done and to put that into their brain and figure out what's best for their patient. I think there are a couple things worth remembering, however. In terms of the hand-sewn intracorporeal anastomosis that Cristiano performed, just let it sink into your brain for a moment that after doing 38 esophagectomies robotically and hand sewing it, he decided he would bring that to the colon. This is in someone who's done thousands of these procedures, hand sewn Whipples laparoscopically. So in terms of there's what you can do and what you ought to do in your hands, and you have to bear that in mind. Likewise with Joel, I mean, beautiful dissection, dissecting. I mean, that was almost like a cadaveric dissection, the view you showed of leaving the superior rectal in place and the veins in place. But I think everyone has to ask themselves, for the patient that they're operating on, do what's safe in your hands. And to me, one of the biggest issues in terms of anastomotic failure, as much as vascularity, particularly in large patients, has to do with length. And I think the surgeon ought to remember that the greatest length you're going to gain, if there's a question of length, is by transecting the IMV. The literature has shown that that's going to get you another 3 to 5 centimeters of length for your colonic conduit to come down to your rectum. And the biggest problems that you're going to have in terms of leak are going to be by having either ischemia or having problems with length. And so the last question before we finish, because we only have 5 minutes, is perhaps the both of you could talk on your thoughts to decrease air leaks. I'm sorry, to decrease leaks. What do you do to test your anastomosis after finishing? And do you use ICG? And before I ask you, I'm just going to say my part and then turn it over. We routinely just use a bulb syringe in the anus and clamp above things. Others use a colonoscope. And we also routinely use ICG. So, Cristiano?
John, we use both, but I don't believe that if you have a good green test and hair test negative, I don't believe that it can prevent a leak in day 2 or 3. They demonstrate that in the time of anastomosis, all is going well, but you don't know what is happening in 2 days or 3 days later. Second, I started my experience with hand-sewn anastomosis because, as Joel said before, when stapler came out, it was a revolution in surgery. And I think that today we have to consider that we have 3 types of anastomosis: hand-sewn, stapler, and robotic hand-sewn, which is a completely different type of anastomosis. It is, you have a very stable field. You can check the margin of your colon when you do the anastomosis. You can check the blood supply inside, and you can take as much as you like in the margin in order to prevent a leak. So they are three different type of anastomosis that we have to consider.
And Joel, your thoughts?
Yeah. Now I have tested ICG. It's particularly interesting for me. I would say on the indication is for transanal approach. When we have to take down bowel, when we want to verify the quality of the vascularization of the proximal segment, colon, and the distal rectum, I have tested ICG, and it was really a good indication to evaluate the quality of the vascularization, because we have not the same view that we have by laparoscopy, particularly now. What we have? We have 4K video, and it is fantastic to because it's close to the same vision that we have with the eyes in normal solar light. And we have to see that, but we have to respect a lot of protocol when we have to do anastomosis. First, early division of the vessels and meso to verified after minimum 20 minutes, so half an hour dissection, what is the color? Because if you divide and you verify it immediately, you can do some error. And it is why it's better to wait 20 minutes to appreciate the quality of the vascularization. It's not immediately, because you are speaking of arteriolar, but you have venous. If the venous drainage is not good, you will have late ischemia. And particularly, probably in obese patients, if you have to do anastomosis in a narrow pelvis, and you will have a compression of the meso inside the pelvis. And so you will have a good quality of vascularization with ICG, but when you will have a compression with edema postoperatively, you will have a problem. So since I'm working in Asia, believe me, but I think the ischemia leak rate, and it was always in emergency, and is around 2%, no more. So this is because we are working with 4K video, we see very well the color, and we see the limit, and if we have a small doubt, using ICG, don't change the choice of the level we will do the anastomosis.
Well, I'd like to thank everyone for joining us, as well as, of course, thanking Joel and Cristiano for sharing their expertise. I would say, in terms of looking at things, the ICG is probably only going to help you a few times during the year, 2 to 5 times maybe in a whole year that you would change something based on it. But that's a lot of heartache you're avoiding, and the cost is quite low. So to answer some of the questions from people chiming in, we routinely do that. So, we had over 125 people from 5 continents join us. Thank you for your attention. I'd like to tip my hat to SAGES for being behind this educational endeavor and trying to bring us educational material during this era of COVID. And please, everyone, stay safe and stay sane. Dan Popowich, thanks so much for shepherding us into the new era with this Facebook page. And until the next time, take care. Bye-bye.
Bye-bye. Bye-bye.
A bientôt, Joel.
Bye, everybody.
Joel. Bye-bye, Joel.
Hope seeing you soon. Bye.
Aspetto un minuto. Non lo sentiamo però. Non so se sta parlando con lei.
What? No? Qua?
O chiudo, è lui che è muto.
Sì. You don't speak. John, you don't speak. I don't hear or you don't
Oh, how
speak.
about now? You hear me now?